Hello, everybody. I was among the team at Derby that are going to be presenting this topic today. So we at Derby had noticed an increasing trend in incidences of congenital hyperinsulinism in our trust, and then we've carried out the study. I would just like to say that we have no disclaimers. So as way of introduction, congenital hyperinsulinism or hyperinsulinemic hypoglycemia is the most common cause of persistent hypoglycemia in neonates and infants. And it's worthy to note that it is the most common cause of persistent ketotic hypoglycemia in neonates and infants. And it's usually associated with a significant risk of permanent brain damage. And of key note is early diagnosis and management are essential to prevent futures of irreversible brain damage, where we could have epilepsy, cerebral palsy, and neurodevelopmental impairment. Now, following birth, early neonates experience a transient fall in their plasma glucose, and this usually stabilizes within 48 hours. This is through adequate substrate availability and intact endocrine system, where there's then a glucose regulation from glucose homeostasis, where you have glycogenolysis or glycogenesis. But however, when we then have neonates who have recurrent or persistent hypoglycemia, despite the initial treatment, you've given them the 48 hours, and then you're still having persistent hypoglycemia, one would want to suspect congenital hyperinsulinism. And in the UK, our CHI centers, we've got 3 of such CHI centers. They've then come out with a criteria, critical biochemical criteria to ascertain if a neonate has CHI. So, and then the first of such criteria is when there is a notable plasma glucose level of less than 3. I think from various studies over the years, there's been a consensus to choose this 3 because less than 2.6 or even less than 2 has been associated with significant impairment of or associated with brain injury. And another criteria is an elevated glucose insulin infusion rate that is exceeding 8 milligram per kilogram per minute. And this is necessary to maintain euglycemia. Other biochemical hallmarks would include elevated serum insulin, elevated C-peptide levels during these hypoglycemic episodes, because as I said earlier, the body has a way of regulation so that we have glucose homeostasis. But if these are still elevated, and then if this is accompanied by low ketone bodies and free fatty acids, which would reflect lipolysis and gluconeogenesis, then that is a significant enough evidence to think about CHI. Now, as I said earlier, we have 3 designated centers in the UK, and these are centers that's designated for, we call them CHI centers. One of them is mainly central in London. We have the Gosh, and then we have the nursery for centers up north, that's usually based in Leeds and Manchester. And these provide a robust guide for the diagnosis and management of CHI as per the UK benchmark. The reason why I brought this up is because we'll be using this benchmark. We use this benchmark in our study to look at how our babies, how we could then include some of these babies into our CHI study. Now, the aim of our study was to determine the cause of CHI in our center and identify factors contributing to the observed rise in the prevalence. And that was the main aim. And then the objectives were to assess the accuracy and timeliness of diagnosis. As I said, we then set that against the benchmark, and then to evaluate adherence to UK CHI recommended investigations, as well as to review initial and ongoing management strategies. And the method we had used was a combined retrospective and prospective study where infants that were admitted into the neonatal unit were then employed to the study. And these infants were evaluated for hypoglycemia, as well as using other biochemical evidences of hyperinsulinism. And as I said earlier, management was benchmarked against a national quaternary CHI center. And over the study 12-month period from October 2024 to September 2025, we were able to collate a number of babies. And inclusion criteria obviously was hyperinsulinism during the study period with persistent hypoglycemia despite usual management plan for hypoglycemia in the first couple of hours of life. And in that 1 year period, we had captured 10 babies. And these are the UK guideline I told you we'll be benchmarking on. And the cardinal criteria was low glucose level, as I said earlier, less than 3, detectable serum insulin greater than 2, and then detectable C-peptide. Ideally, C-peptide in a when you carry out C-peptide in a normal unit, it shouldn't be more than 0.2 to 0.4. So if it's way elevated, then you should be considering CHI. And then we also looked at the biochemical features, the clinical evidences, as I've also alluded to. And then if there's any positive glycemic response to glucagon as part of the management plan. And then, of course, all these other supportive evidences. Now, the results. During this period, if you look at the graph, there was a steep increment. It initially had started and then steeped at the end of 2024, and then there was just a very sharp incline at 2025. So this was what was observed, and that was quite interesting. So we wanted to get to the bottom of this. And of the babies we had, the demographs had showed we had more terms than preterm babies, and then we had more males than female infants. But other than that, there was really no specific racial predeletion, even if we had 4 babies that were white. But of notice, this is a white, predominantly white area. So it was okay for us to have, 4 white babies. But looking at it, there was really no racial predeletion. Then 30% of these babies, we found that were delivered to infants of diabetic moms. Majority of them were diet controlled. So it wasn't as though they were taking anything exogenous that would have caused the increased hypoglycemia or hyperinsulinism. And then of that 30%, one of them was also IUGRO. And then 20% of the mothers, which was quite interesting, were also on PET. And they were on had pregnancy-induced hypertension, so that's short for PET, and they were on labetalol. But delving deep into the mothers' clinical features and their numbers, there was really no antenatal risk factors. And then we went down and dug into the C-peptide results, and we had quite an impressive range of results. So remember what I said earlier, you shouldn't really detect C-peptide in blood, but some of these infants had up to a range of between 541, even up to 2,989 nanomole per liter, with mean C-peptide being about 1,300. And then the least insulin values we obtained was 54.2, which again was markedly elevated. And we had a range of between that 54 and 5,000 with a mean insulin of about 900. And then when we came down to calculating the GRO, by the time we're making the diagnosis, the mean was about 13, plus or minus 0.9 milligram per kilogram per minute. So of these 10 babies, only 6 of them had FF-free fatty acid levels done, and all the beta hydroxybutyrate levels were less than 0.1. Remember, what we're trying to attribute was the blunting of the fatty acid response to hypoglycemia that is expected in CHI. And it was interesting to note that 6 of our babies had this blunting, and they were all 6 that had FFA sent as a result. And then again, obviously, all those babies had hypoglycemia. Now, we benchmark what we were doing against the standard. collected critical samples in all 10 of our babies. Insulin and C-peptide were also done in all 10 of the babies, and we had calculated JR. As I said, only 6 had free fatty acid and beta-hydroxybutyrate measured. Now, of those that require treatment, initially, it's a stepwise treatment. So initially, you try and increase the glucose infusion. And then if that is not working, you then have a glucagon trial. So 2 of those babies met criteria for glucagon trial. And then 5 of these babies, of those that it was indicated, with subsequent hypoglycemia, had dioxazide given. And then echo, because part of the plan is to do an echo before you give diazoxide, because you need to be sure there's no raised pulmonary pressures. And then we did liaise with our CHI center just to see if there was anything or any input in terms of the management. And then of 3 babies, we finally sent genetics, because looking at their family history, we realized that some of these mothers had also previously had neonates with CHI. 3 of them, we couldn't get any genetic subtypes. So their genetic results were all negative for CHI. So as at the end of the study, we didn't have any common genetic subtype that causes CHI. And then we did a bit of supporting evidences like ammonia and cortisol, just to be sure we're missing anything or that was causing the hypoglycemia. Of those babies that required diazoxide, some of it was quite interesting to know that even from day 3 to day 20, we had started diazoxide to try and improve the hypoglycemia. And 2 of these babies required increments in diazoxide because we just weren't getting euglycemia. And then only 2 of the babies who had required diazoxide or who had gone on to have diazoxide had also gone through the glucagon trial. And at the end of the day, by the time they were being discharged or by the time they were being normalized, all the babies that had diazoxide also had glucose polymer. In here, we call them Mathews, just to maintain euglycemia. And 3 of the babies only needed increased glucose concentration with no subsequent need for Mathews. So we ascertained that this may have been transient hyperinsulinism, and we discharged them on normal formula and breast milk. And as per guideline, they were then followed up subsequently to ensure that they had euglycemia moving forward. And what was interesting was at the time they were going home, even those who were discharged on diazoxide, all of them had successfully completed a 6 hours fast that was normal before we discharged them. So looking at these results we'd gotten, what we had set out to do was to try and find out, tease out among the 10 babies, what really was causing the significant increase in CHI cases we're having. Other than the 10 babies being prevalent and then majority of them being males, there was really no other common risk factors other than probably the IgM and IUGRO, which are occasionally risk factors for CHI. And then it was kind of surprising, maybe because of the small number, to see that there was nothing we could really tease out to be common link between all the babies. And then for those that had high levels of C-peptide, insulin, and they were confirmed as CHI, there was no genetic cause that was singled out because we do have a CHI panel. But we did conclude that early recognition and prompt biological evaluation, just imagine if we hadn't picked up these babies and then set out to do all these, especially those who went home on diazoxide, if we hadn't set out to do all these investigations, we may have missed those babies, and then maybe down the line they would come down neurological morbidity, and it would just most likely just been a guess game as to what would have caused it. And then, as most of you would have noted, it was just 10 babies in a 1-year period. So I think more work will still be done. I know there's a lot of work going on in Exeter in the United Kingdom to try and find out, looking at the whole of the United Kingdom, if there's to explore any underlying genetic and population level contributions to rising incidences, especially as regards to CHI. We've I mean, the London GOSH has earmarked some genetic prevalences, but not all babies who still end up having CHI have the most common subtype of genetic isotypes. So I think we'd wait and see what the future holds for us. But of note is the reason why we had set out to do this was majority of these babies were just normal babies who were born. They had hypoglycemia, and as per the guideline, you just manage them for hypoglycemia, and then they get better. But some of them did not even have symptoms. So it was a case of probably an IUGRO had a BM, then subsequently got got their blood sugars done, and that was where hypoglycemia was indicated or identified in the first instance. So that brings to mind that hypoglycemic symptoms, though they vary widely, we just need to be very vigilant. So what we've told ourselves in our center was for every baby whom we're doing, especially if they're at risk, and we are doing the observations for heart rate, respiratory rate, SATs monitoring, perhaps BM should just be one of the things we should be doing, even if it's just a spot check at the initial or the first instance. And another take-home message is in CHI, the lack of alternative fuel production increases the risk of brain injury and neurodevelopmental impairment during hypoglycemia. So we need to identify these children and ensure they don't stay in hypoglycemic episodes for too long. And of course, early recognition and prompt treatment is indeed vital in preventing brain injury. If in doubt, just take a blood glucose level. So together we can protect the brain of the neonate. Thank you so much.